We know that there were only a couple of deaths due to ILD pneumonitis in this trial. We don't know how to predict who those patients are. We're leaving out the one piece that makes us all a little nervous, which is the toxicity element of interstitial lung disease. You know,
excellent transition point. Yeah. So you mentioned it, so you can take it on.
I know I probably shouldn't have wanted to take that one on, but I think, you know, if we didn't have that toxicity there, where we're hoping these patients have long-term survival, like, would it weigh on us so heavily to be using cytotoxic therapy right now? I'm not sure that it would. I think the lack of a maintenance phase without cytotoxic and having this potentially long-lasting and fatal toxicity, even though it's rare, right? We know that there were only a couple of deaths due to ILD pneumonitis in this trial. We don't know how to predict who those patients are. If we could, if we knew who needed this benefit, who was more at risk of ILD, I think that would make us all a little bit more comfortable, because we're still in that, you know, don't harm these patients who could live for many, many years.
So when the drug was first being developed, and it's probably still in some of the recommendations to be evaluating patients above and beyond querying them about side effects, scans every, 6 to 8 weeks. So can you envision doing that long term in somebody who's on it for?
Yeah, that's one thing I've thought about the trial, because definitely in my patients who are on the Cleopatra regimen and have been on it for years, we're either scanning every 6 months, once a year, only in the presence of symptoms, depending on the patient. So the idea that we need to scan more rapidly to look for ILD, I'll probably back off a little bit if they've been doing well for a while, and encourage them to come to us very early, make sure that the patients fully understand how important it is to come to us early with any cough or other respiratory symptom. But I think that does just add to the burden of the regimen.
Yeah, and we do have these patients that get some shortness of breath, or whatever, they're grade 1, I guess. Do you have any reservation about reintroducing trastuzumab deruxtecan?
No, with the grade 1 toxicities, respiratory toxicity, just radiographic changes of pneumonitis, I think we have actually a good amount of safety data right now where we feel comfortable with that. And in clinical practice, I think we've all done it. And it's always on your mind, because many of those patients are benefiting from therapy when you see that they have this radiographic change on the scans. And, all of us in the Midwest, we know that this viral season, it makes your life hard, because is that cough just that virus that's going around, or is it something more? And you would hate to stop active therapy if you really didn't have to. So for the grade 1s, I have no qualms about re-challenging. I always wonder a little bit about those patients who maybe are mildly symptomatic, and can we come back around to the drug? And of course, per the guidelines right now, we can't, right? As soon as a patient is symptomatic, we should withhold any more T-DXd. But I think it's an area of concern that, we as a field will be thinking about in the future, especially if patients are on this for a very long time.
Yeah. Any different view on that?
No, I think I agree.
So